Tell me. So let's finish up the lower respiratory lecture. So we're going to start here with atypical mycobacteria. Um, basically, there are 30 different varieties of mycobacteria that typically cause pulmonary disease. And this is a bacteria that's found in tap water, dirt, dust, bird feces. So when patients who are homeless, patients who don't have clean running water or city water are at an increased risk for mycobacteria. It's a lung infection, so we're going to see some of the very same symptoms: cough, shortness of breath, weight loss without trying to lose weight, fatigue, and then bloody sputum or hemoptysis. We diagnose this just like with TB based on the sputum culture. We have to know what type of bacteria we're dealing with in order to know specifically what antibiotic to use to make sure that we're treating it appropriately. And then the treatment is similar to what we saw with TB, with the multiple medications, the the long time frame that the patients are taking the medications as well. For patients with fungal infections, we have to treat them with antifungal medications. So they're going to have similar symptoms to what we saw with bacterial lung infections: cough, fever, um, shortness of breath, fatigue, all of those things. But because the fungus tends to encapsulate itself, fungal infections can be more severe and more difficult to treat and can last much longer. Um, so we diagnose this based on skin testing. We check the blood for signs of the fungus, and we also do a biopsy of the area to determine what is growing. And then, of course, we treat with antifungals that are designed to kill the specific fungus that the patient's infected with. Lung abscesses is basically when a bacterial infection kills off the lung tissue. And then you end up with this large sac of purulent fluid in the lung cavity. So we're going to, because it's typically bacterial, we're going to treat with antibiotics. But some patients will develop multiple abscesses, which is diagnosed as necrotizing pneumonia. So the lung tissue starts to die. So again, because this is a lung infection, the respiratory system is involved. We're going to see a cough with purulent sputum, so green, dark sputum. It typically will have a foul smell or a foul taste because it's bacteria. And then sometimes, because the tissue is starting to die and necrose, we'll see bloody sputum as well. These patients will also have fevers, night sweats, pleuritic chest pain, shortness of breath. They'll lose weight, again, without trying to. It's just because of the increase in metabolism, because of the increased effort it takes to breathe, and the body is focused on trying to fix the lung problem. We're going to hear a decrease in lung sounds over the area of the abscess. Because fluid is also drawn to the area, we'll also hear crackles in the lungs. Complications could include a larger pulmonary abscess, multiple abscesses, the openings. As that tissue starts to necrose, fistulas can form between different areas of the lung, which can cause problems. We can have collapse of the alveoli or of the lung itself, and empyema as well can be considered or is a complication. We diagnose these abscesses on an X-ray or a CT scan. We have to visualize the abscess. We want to get a sputum culture to determine what bacteria is present and causing the abscess. We also want to check the pleural fluid for the presence of bacteria, as well as blood cultures to determine whether or not the patient is septic We could do a bronchoscopy to actually visualize inside the lungs and see the extent of the necrosis. And then we want to check a white blood cell count just to determine whether or not it's elevated. We're going to monitor the patient's oxygen, give supplementary oxygen as they need it. Their lung tissue is dying. And if the tissue is dying, gas exchange can't occur in those tissues. So we want to give supplementary oxygen to help keep their oxygen level up and keep their other organs perfused. We'll give IV antibiotics initially because we want to get large doses in very quickly to start to kill the bacteria. And then once that initial treatment of IV antibiotics has ended, we'll switch them to an oral antibiotic based on the culture and sensitivity. We also want to educate the patient, the same education that we give to all patients who are taking antibiotics, the importance of taking all of the medications, the importance of reporting worsening of symptoms or a lack of improvement so that we can properly treat the patient. We also want to support the patient by educating them on how to cough effectively to get rid of some of that sputum that's in their lungs. We want to make sure they're hydrating so that we thin those secretions so that it's easier for them to cough. And we want to make sure that they get sufficient rest to give their body an opportunity to heal and are eating proper nutrition or eating a properly nutritious diet so that they have the nutrients they need for their body to heal. Dental care is also important. And I know that, a lot of people look and they say, well, why does it matter about brushing my teeth? Well, the mouth is a direct portal of entry for bacteria. And we know that the mouth, because it's a dark, moist place, promotes bacterial growth. So what we have to do is make sure that we rid that bacteria or clean out that bacteria in the mouth as often as possible to prevent it from overgrowing, because poor oral hygiene can lead to pericarditis, it can lead to lung abscesses, pneumonia, and other respiratory infections as well. If the antibiotic is not effective, so if they've taken the IV antibiotics and they're on the oral antibiotics and things just are not working, we can do a thoracentesis or a percutaneous drainage of the abscess to remove it surgically. And if that doesn't work, if the necrosis is severe enough, we can actually remove the entire lobe that's affected or even the entire lung if we need to prevent worsening of the patient's condition. Environmental lung diseases are those that come from the things that we breathe in. So dust, chemicals, asbestosis is one of those that we see commonly. Not so common anymore because buildings are not built with asbestos anymore. But in construction workers or demolition, people who do demolition, particularly of older buildings, they're at an increased risk for environmental lung disease like asbestosis, as the chemicals in that are no longer used, but that we know are damaging to the lungs as those particles are released and they breathe them in. This is one of the conditions that a lot of people who were present at the Twin Towers during 9/11, a lot of them developed these types of lung diseases because of the inhalation of those chemicals as the buildings came down. The amount of lung damage is going to depend on how long they were exposed, how much of the chemical they were exposed to, the overall lung health or susceptibility of the individual, and then the toxicity, the level of toxicity of what they breathe in as well. So some examples, we have black lung. If you've ever watched one of my husband's favorite movies is Zoolander, and his family works in the coal mine. He goes in for one day and then starts to cough and says, "I've got the black lung, Pop." Well, he didn't have the black lung after one day. These are people who have worked in coal mines for years and years and have breathed in these minerals and dust particles, sand and rock, and develop pneumoconiosis. in their lungs. So it's a type of pulmonary fibrosis. So the lung tissue hardens, and it's less effective at what it's supposed to do. I already mentioned asbestosis, which can lead to mesothelioma and other types of cancer, but you don't see the cancer until sometimes up to 20 years after the exposure. So it's really important to teach these patients to wear their masks when they are um, in these environments, because that's going to help to protect them. Chemical pneumonitis is from breathing in toxic chemicals. So we see a lung injury, inflammation in the lungs quickly, and then chronically, we'll see a bronchiolitis obliterans. So basically, those bronchioles no longer function. They're chronically inflamed, chronically damaged, and don't work properly. Hypersensitivity pneumonitis is one from allergies. So we'll see that often in people who spend a significant amount of time around the things that they're allergic to. Bird droppings is one thing that a lot of people don't realize they have a hypersensitivity to. Bird feathers, there's lots of particles and germs on the bird feathers. It's the same for roach. Roach parts, like body parts that are breathed in, as well as roach feces, is another type of hypersensitivity that a lot of people are unaware of. So if you have particularly children with these allergies living in environments that aren't very clean, they're at an increased risk for hypersensitivity. So again, because these are lung conditions, we're going to see the same types of symptoms: shortness of breath, cough. Here, because we have the swelling of the airways, the inflammation of the airways, but not the sputum, we're more likely to hear wheezing than crackles. So with our other conditions that had fluid in the airways, whether it was from bacteria or fungus or viruses, we heard crackles because there's fluid in the lungs. Here we have a narrowing of or a fibrosis of the airways, so we're going to hear a wheeze. These patients will receive pulmonary function tests. We'll do chest x-rays and CT scans to see how severe their lung involvement is. And because of chronic lung involvement, they can develop right-sided heart failure, just simply because the heart is having the increased pressure in the lungs makes it difficult for the heart to push the blood into the lungs. So the heart, that right side of the heart has to work harder in order for the blood to get into the lungs. So that tissue starts to thicken, it gets harder, it doesn't function properly, and so we end up with signs of right-sided heart failure as a potential complication. Also, these patients can develop COPD, chronic bronchitis type symptoms, particularly those patients with the asbestosis and chemical exposures, chronic chemical exposures from their work. We could also see some pulmonary edema, so fluid coming into the lungs. Some of these patients, as we talked about, develop lung cancer and mesothelioma. They're also at an increased risk for tuberculosis because of their exposure. Ultimately, we want to prevent these diseases. A lot of the OSHA regulations that come down from the federal government are now put in place and are designed to prevent these conditions. Teach the patients to wear their appropriate PPE and their masks. There needs to be proper ventilation in these areas so that the chemicals are filtered out of the air that's breathed in. And these patients also need regular follow-up visits. They need oxygen, hydration, bronchodilators. We can give corticosteroids to help with the inflammation. We can give non-steroidal anti-inflammatory medications to help with the pain and some of the inflammation. And then when their condition progresses and worsens significantly, they may need intubation and mechanical ventilation, as well as percussion to help loosen some of those secretions, and could potentially need pulmonary rehab. For these patients, because they already have lung damage, we will also want to make sure they get all of their vaccinations to prevent other respiratory diseases like the flu or COVID or pneumonia as well, because to get one of those conditions on top of their already poor lung condition from these environmental diseases could be fatal for some of these patients. So again, we're going to do a thorough physical assessment. We want to do a general assessment. We want to assess these patients. This is lung cancer. So we are not going over lung cancer. You're going to go over lung cancer in adult health too. So we are not focusing on lung cancer. But for every lung disease, you want to do a thorough assessment of both subjective and objective data. Now, we've already discussed, you've discussed pneumothorax, or at least the pathophysiology of a pneumothorax. So we're not going to go over the pathophysiology, but we are going to talk about, again, the manifestations. So the patient has a collapsed lung. So you see in this image here, the lung is no longer inflated, and all around it is air. This can come from a puncture of like through the ribs, like damage to the ribs, so that air from the environment is getting in to the lung cavity. It can also come from a puncture in the lung itself, and so the air that's in the lung is released. So these patients are going to clearly have shortness of breath. Their heart rate will increase. They may have some significant chest pain or discomfort. You will not hear breath sounds in this area because there's no air movement in the lungs. So you're only going to see or hear lung sounds on the side of the lung that's been inflated. And we diagnose this on chest x-ray. So a spontaneous pneumothorax we often see with tall, very thin males. They typically have a family history of a spontaneous pneumothorax, and it is truly spontaneous. There is no activity or action that makes it more likely. They are just standing, walking around, going through their normal activities of daily living, and all of a sudden they have difficulty breathing. So it can occur in healthy, young, tall, thin adult males. You can also see it in people with chronic lung diseases just because the lung tissue is not healthy. And then sometimes we can cause it through our medical procedures with biopsies, central venous catheters, patients on ventilators, or patients who've got esophageal trauma are also at an increased risk. So if you're assisting with any of these procedures, you need to be aware that pneumothorax is a potential risk, adverse effect of that procedure, and make sure you're monitoring the patient for signs of a pneumothorax. A tension pneumothorax, though, is when air accumulates in the pleural space and can't get out. Typically, that's it can come, you can have an open pneumothorax that comes from an opening. You can also have an opening in the chest wall. It can also come from an opening in the lung itself. So you see here what you see on a tension pneumothorax. Your superior vena cava is here, your trachea is here, and your trachea deviates towards the lung that is still inflated. So you see this lung is deflated. This is the midline. So the trachea shifts towards the side of the inflated lung. So that's a key sign of a tension pneumothorax, is that medial shift of the trachea, or tracheal deviation is the term that we use. So for a tension pneumo, again, you're going to see the tracheal deviation, and then the other symptoms are the same: cyanosis, diaphoresis, shortness of breath, tachycardia, no lung sounds on that side. The difference with the tension pneumothorax, though, is that the trachea deviates to one side. So how are we going to care for these patients? Well, for patients who have an open chest wound, we want to make sure that we cover the chest wound, but only on 3 sides, because we want to maintain the pressure gradient between the internal thorax and the external environment. What'll happen is as the patient breathes, it pulls the dressing against the wound so the air can't get into the pleural space. But when the patient exhales, it allows the air to escape so that the air that's leaving the lungs doesn't just fill up the lung cavity. If the patient was impaled with an object and that's what's causing, let's say, a stab wound, and that's what caused the pneumothorax, then you want to stabilize that wound with the bulky dressing, but you don't want to remove it. It can be fatal if you remove it. So we want to leave it in place until the patient most likely goes to surgery. These patients will get a chest tube. You've all done your chest tube review on ATI, so make sure you understand the nursing implications. So what are the nurse's responsibilities when it comes to putting in the chest tube and maintaining it? Sometimes the doctors will go in and they will surgically tack the lung to the pleural cavity so that it is less likely to deflate. For a tension pneumothorax, we have to get rid of that extra air that's inside the cavity. So we'll do a needle decompression with a large, usually a spinal needle because they're very long, in the second intercostal space. So let's go back to the picture. Well, my lungs aren't my ribs aren't showing, but what you'll see is you'll come down. So the clavicle is here, then you've got the first rib and the second rib. So in that second intercostal space, you're going to take a needle, a long needle, and you're going to just insert it until you start to hear the hiss of air. And that will help to get rid of the extra air that's inside this area and allow the lung to reinflate. So again, the second intercostal space. If you've ever seen any emergency medical show where they pull out a ballpoint pen and they take the inside piece of the ballpoint pen out and they jam it into the patient's chest, that's a needle decompression. Of course, in the hospital, it's done in a much more controlled way, but that's what the needle decompression is. And then once we have reinflated the lung, these patients will also get a chest tube with water seal to make sure that the lung remains inflated. So again, make sure you go back and review your chest tube information from last semester and from your ATI module. Restrictive respiratory diseases are those that make it difficult for the chest wall to move or for the diaphragm to move. So again, the lungs are not able to fully inflate. So our symptoms are the result of that difficulty inflating. For some people, it's not damage to the chest wall itself. It's actually an issue with the central nervous system. So the diaphragm, that phrenic nerve that goes through the diaphragm, is not functioning properly for some reason. And so the chest wall can't move like it needs to. So what we typically see with these patients is a decrease in their expiratory volume. So the amount of air they're able to exhale decreases on their pulmonary function test. We already talked about atelectasis. It's a collapse of the alveoli. We see this a lot in patients who have immobility, so they are bedridden, or patients who maybe have some immobility due to being postoperative or their current condition. So after surgery, patients are at risk for atelectasis because they're not moving properly. So the key here, and the way we prevent it is the same way that we treat it. We want to do things that are going to fully inflate the lungs. That includes deep breathing exercises, incentive spirometry, making sure the patient is up and walking around, because that's going to promote lung expansion. So anything that promotes lung expansion helps to prevent or treat atelectasis. Pleurisy, again, we've already talked about this, is an inflammation of the pleura that surrounds the lungs. It often comes from infection, but it can also come from other things, medication, trauma, even autoimmune disorders. You're going to see the patient will complain of sharp pain that gets worse when they take a deep breath. They'll breathe very shallow because it hurts to take a deep breath. And what you'll hear when you listen is a pleural friction rub. So the way we treat pleurisy is to treat what's causing it. If it's coming from an infection, we treat the infection. If it's coming from cancer, then we treat the cancer. It can also come from reflux and pancreatitis, so we could treat those GI disorders as well. And we also want to give them treatment for their pain. Pleural effusion is a collection of fluid in that pleural cavity, and it's a sign of an underlying disease. The pleural effusion itself is typically not the primary problem. It's a symptom of one of those other issues. So severe pneumonia that we talked about, the lung abscesses, tuberculosis can all lead to a pleural effusion. It's a collection of fluid outside the lung in the pleural cavity. So we're going to treat those. What you're going to see again is all related to the fact that that lung can't fully expand. There's fluid in the way. So you'll see shortness of breath. The patient will have a cough. They'll complain of that pleuritic chest pain. You'll see decreased chest movement. The patient will, you'll hear dullness when you percuss and diminished breath sounds over that area. We diagnose this with a chest CT or an X-ray to make sure we know where the pleural effusion is and how large it is. Sometimes that effusion is an empyema, which is a collection of pus, not just fluid. So we need to, for those patients, they're going to have signs of an infection. So fever, sweating at night, still a cough, and now the weight loss because of the infection. So again, because the pleural effusion is a symptom and not the condition itself, we're going to treat the underlying cause. So we'll treat the pneumonia, we'll treat the TB, we'll treat the lung abscess, and that will get rid of, hopefully, the pleural effusion. Sometimes we need to do a thoracentesis and remove the fluid through the procedure. But sometimes it just resolves on its own, and the body reabsorbs that fluid as you get rid of the underlying cause. Interstitial lung diseases are those that affect the interstitial tissue within the lungs. So our parenchymal lung diseases, pulmonary fibrosis, sarcoidosis, those they cause inflammation and scarring in between the air sacs. So the tissue the interstitial tissue, inter means in between. So this tissue that's in between the air sacs gets hardened from inflammation and scarring. Sometimes we don't know where it comes from. It's idiopathic. Sometimes it's sarcoidosis and it's a genetic or autoimmune disorder. But we treat the patient based on the underlying disease. So if it's from an exposure, like a chemical irritant, then we want to remove them from that area and then treat the condition with corticosteroids. If it comes from an autoimmune disorder, then we want to give them immunosuppressants along with the corticosteroids. And if the condition progresses enough, they may need a lung transplant. So pulmonary fibrosis comes from, again, chronic exposure. So we see this in patients who work who smoke, but who also work around wood and metal dust frequently. They're going to show signs of chronic respiratory conditions or problems. So dyspnea on exertion, a cough, you'll see clubbing of the digits, you'll hear crackles. Over time, they show weakness and anorexia. And we're going to diagnose this based on their pulmonary function test as well as a lung biopsy. That's the best way to determine whether or not they have fibrosis of the tissue is to actually examine that tissue. We're going to treat these patients again with corticosteroids and immunosuppressants. Kinase inhibitors, we know kinase is released as a part of the inflammatory process and can lead to inflammation and scarring. So we want to inhibit that. We'll give them oxygen. They may have to get pulmonary rehab and possibly lung transplants. Sarcoidosis is an autoimmune disorder, but it has the same signs and symptoms. We'll see dyspnea, cough, chest pain. Sarcoidosis, though, does not only affect the lungs, it affects other tissues as well. So you'll see vision changes, you could see liver damage, kidney damage, even heart issues. It's more prevalent in African American communities and patients with a family history. We treat it by suppressing the inflammation, so giving anti-inflammatory medications. These patients take long terms of anti-inflammatories and corticosteroids, immunosuppressants. Every few months, they're going to get pulmonary function tests and chest x-ray to determine the progression of the condition. Vascular lung disorders are those that bring fluid and blood into the area. So pulmonary edema, we see with left-sided heart failure as the fluid backs up into the lungs. Pulmonary emboli are blood clots that form in other areas and then travel to the lungs. Again, the symptoms of pulmonary edema and pulmonary embolus, and here's an example of a pulmonary embolus, a blood clot in the lungs. But the symptoms are all based on the fact that the airway is blocked and air can't get through. So we want to prevent DVTs and VTE and do all the things we know need to happen to prevent the embolus. So early ambulation after surgery, sequential compression devices, embolic stockings, blood thinners, daily aspirin therapy, all of those things are going to help to prevent the embolus. We know the things that increase the patient's risk for a PE are the things that increase clotting. So immobility, surgery, particularly of the pelvis or the lower extremity that prevent movement, a history of having a blood clot, and then patients who are obese, patients who use oral contraceptives, who smoke, are also at higher risk. Again, we're going to see shortness of breath, and all the signs of a blocked airway. So decrease in their lung sounds, possibly pulmonic heart sounds, a decreased oxygen saturation. If the embolus is large, we'll see very quickly a change in their mental status. They'll have a sense of impending doom. They feel like they're about to die, and we'll see hypotension. PEs, if we don't take care of them, can lead to a pulmonary infarction. So the vessels in the lungs get occluded and the lung tissue starts to die, similar to what happens in a heart attack. We can also see some pulmonary hypertension, which can lead again to right-sided heart failure because it makes it difficult for the right side of the heart to push the blood into the lungs. We want to check a D-dimer, so make sure you know your lab values, which shows that a clot has been formed. If the PE is small, though, sometimes the D-dimer is still negative, so we still have to do a CAT scan to check under contrast to determine whether or not there's clotting in the vasculature within the lungs. We'll do a VQ scan to determine how well the patient is perfusing and how well they're ventilating. We can also check these. Now, these do not diagnose. They just check for signs of complications and other problems. So ABGs, the chest x-ray, and EKG, natriuretic peptides and troponins all help us to determine if there's cardiac involvement with the PE as well. We want to make sure that we are lowering the risk for the PE. We want to prevent them, ultimately, is the goal. But if once they already have it, we're going to provide oxygen. These patients may have to be intubated and put on a ventilator. We want to prevent atelectasis, so using the incentive spirometer, turning, coughing, deep breathing, ambulation are all ways for us to prevent atelectasis and worsening of the lung condition. We want to observe the patient for signs of shock and make sure that we're giving them fluids and maintaining their blood pressure. If they do develop heart failure, we're going to give diuretics. And then we can also treat the pain with opioid pain medication. Make sure you know your nursing considerations for our blood thinners, heparin and Coumadin, TPA, and alteplase if the patient has a PE. So as the nurse, what is it that you need to assess for before the patient gets these medications? While they're receiving them, what assessments do you need to do? What complications do you need to be aware of? Typically, it's signs of bleeding before, during, and after administration. If the PE is large and it's filling up a large airway, we can surgically remove it through an embolectomy. This is typically done on patients who are not stable and those who cannot receive heparin therapy. Pulmonary hypertension, again, is not typically in and of itself a condition or a disease. It's a result of other issues, but it comes from an increased resistance inside the lungs. So the pressure inside the lungs, which is typically between 12 and 16, increases to greater than 30 during exercise. And it's typically, again, a secondary complication, but it can be a disease in and of itself. So we have idiopathic pulmonary hypertension, so it doesn't come from any other secondary disease. But we're going to start to see scarring within the lung tissue, which can lead to um, hypertension. All right, I'm going to pause here for lower respiratory. And this will be the end for lower respiratory. I'm going to pause the recording now, and we will move on to the next thing. All right. So, for those of you who logged in a little early, I was finishing up the recording for lower respiratory. Something happened with. Morning, everybody. We are going to